Our next speaker is Dr. Jean Frazier. Jean is Vice Chair and Director of the Division of Child and Adolescent Psychiatry and Professor of Psychiatry and Pediatrics at UMass Medical School, where she holds the SIF Endowed Chair in Autism. Jean leads the Child and Adolescent Neurodevelopment Initiative at UMass. This group is a research group committed to rapidly advancing the understanding, diagnosis, and treatment of individuals with neurodevelopmental disorders, including early onset bipolar disorder, schizophrenia, and autism. Her lab has been engaged in numerous neuroimaging and clinical trial research efforts, several projects sponsored through the Autism Consortium, and a number of novel treatment studies for autism and Fragile X. A very active member of our steering committee and a PI in our biomarkers project, it's my pleasure to welcome our friend and colleague, Jean Frazier.
Thank you very much, Dee Dee, and thank you to Stephanie and to the Autism Consortium for inviting me to speak on a topic that's near and dear to my heart. Eric Morrow earlier talked about Bradley Hospital, and I actually specifically chose to do my child fellowship at Bradley Hospital because they have such expertise in this area. It was clearly important for me to try and understand how, on a clinical level, we can improve the lives of individuals who have intellectual disabilities, specifically autism. So I'm talking to you today on medical and behavioral conditions seen in individuals who are on the spectrum. And before I start, as Dee Dee mentioned, I'm actively engaged in multiple research projects, and I'd like to just disclose we are funded through NICHD, NINDS, also NIMH, and we are actively engaged in multiple novel intervention studies that are funded through pharmaceutical companies. So my objectives today are to really outline for you the medical conditions that are typically seen in autism and to highlight the challenges involved in making an accurate diagnosis. And secondly, to then review some of the literature that highlights rates of psychiatric comorbidities. We've heard this earlier today, but just to set a tone, the rate of autism is increasing annually by approximately 20%. The latest figures have come out from the CDC that it affects 1 in 88 children, and this is based on the 2008 data. For those of you who have a family member, you fully understand the complexities and trying to garner sufficient support. From a financial perspective, it costs about, on average, $1.4 million to care for an individual on the spectrum across the lifespan. If you add in an intellectual disability on top of that, it costs about $2.3 million across the lifespan. Unfortunately, we don't really have medications that treat the core symptoms. Some of the newer research efforts are aiming to target those core deficits. What we typically do from a therapeutic and supportive standpoint is we deploy behavioral interventions, or in my realm, deploy psychopharmacology. There are a number of agents that are out there that are being used pretty routinely, and we have 2 agents that have been FDA approved, those being aripiprazole and risperidone to treat the irritability seen in autism, but they don't target necessarily the core deficits seen across these disorders. So the coexisting developmental behavioral conditions often typically worsen the symptoms of autism, and what I mean by coexisting developmental or behavioral conditions are things such as cognitive impairment, which occurs in about 25% and is more common in those with autism. Also, emotional regulation disorders, sensory processing disorders or sensory integration dysfunction, and maladaptive behaviors such as aggression or self-injury. But more importantly, I'm here to talk to you at least a little bit about the comorbid medical conditions. Very recently, just so that you are aware, there was a primer that was released for healthcare providers and also for policymakers. It was pulled together by Treating Autism, which is out of the UK, and also Autism Treatment Trust out of Scotland. And they really pulled together a nice primer that pulls together all the information in the field about comorbid conditions that occur in individuals across the lifespan on the spectrum. This is a quote from an article that was written in 2012, and it says, comorbidity is to be expected in autism spectrum disorders, directly or indirectly. Comorbid conditions may be markers for underlying pathophysiology and request a more varied treatment approach. So I see a lot of families that are sent to me because there's been a change in behavior or some form of dysregulation amongst the children in their family. And it's not terribly uncommon, if you probe a little bit, to find out that there's been some sort of acute change that precipitated the change in behavior. So it's critically important as a child psychiatrist to be thinking first and foremost medical. Is there a medical condition going on that's fueling this acute onset or exacerbation of maladaptive behavior? And often there is a reason. It's either medical or it's environmental. So it's not uncommon for a nonverbal child to come in to my office with extreme exacerbation, for example, of agitation or even aggression, and it's being driven by having a toothache or an earache. And in that instance, the treatment is sharply different from pharmacotherapy. So it's very, very important as a clinician to be a detective and to really think about what might be going on and to rule out both medical and environmental considerations prior to thinking that there might be a comorbid psychiatric issue. Now, this is actually from this primer, and I want to share a number of facts with you. The CDC recently did a survey and found that across all medical conditions that they surveyed, that individuals on the autism spectrum had higher rates of all the medical conditions studied, including the following: eczema, allergies, asthma, ear and respiratory infections, gastrointestinal problems, severe headaches, and migraines, and seizures. The Autism Treatment Network also has contributed enormously to the literature in this area. Interestingly, according to a survey that was done in 2009, 81% of parents of youth with ASD stated that their health concerns for their child had not been adequately investigated by professionals. Out of those that answered this survey, a full 70% said that at least 4 times maladaptive behaviors were attributed to autism rather than consideration being given for an underlying medical condition that was fueling the behavior. And that happened at least 4 times before they received appropriate treatment. What about adults with autism? They're at heightened risk for a variety of things, but particularly for diabetes, coronary heart disease, cancer, osteoporosis, and often these are not attended to. In another survey, 1/3 of high-functioning adults reported that they did not receive appropriate medical care for their physical health problems. And these are the high-functioning verbal folks. So imagine what the rate must be for those who are lower IQ and nonverbal. In those who have been found to have a comorbid medical condition, parents were told in the past that it was part of the autism, there was nothing going on medically, sent home multiple times before receiving the proper diagnosis. So this is a critically important area. This is a unique patient group with unique issues. Often they have a poor ability to report physical symptoms and sources of distress. Often they have unusual tolerance to pain, and These missed medical problems may drive surface features that resemble psychiatric disorders. For example, irritability, lowered threshold for baseline externalizing behaviors, poor appetite and sleep. How many parents come in and complain that their child's not sleeping? And there's a sharp change in that. Motor restlessness. I would add a number of other things to this. Clumsiness, awkwardness, inattention, anxiety. These are not all part of autism spectrum. They can co-occur, but typically, if there's an acute onset, there's likely something else going on. So, behaviors in ASD are often physical in origin, they're identifiable through a thorough investigation, and they are treatable through appropriate medical care. I'd like to share 3 brief vignettes with you. Just recently in my practice, I had a mother call me and she said, "My son is regressing. He's toe walking, he's engaging in stereotypies, which he hasn't done for years, and he can't eat." So I said to her, "You need to go to your pediatrician and have him checked." Turns out he had a strep throat, but it was treated twice over. He improved with the treatment of the infection, but he's had a recurrence of the infection at least 2 more times. Okay? So that did not require a psychotropic intervention. Secondly, 15-year-old nonverbal boy that I've treated for years had new onset of seizure disorder, was started by neurology on an anticonvulsant. That anticonvulsant didn't seem to be helping. Mother was calling me and emailing me late at night, almost every night, saying he's terribly aggressive, we have to lock him into his room, and he's been bolting. I'm really afraid for my life, I'm afraid for his life. She kept in touch with me, and she kept saying his diet has changed. He's eating things he's never eaten before. He's eating, in 2 days' time, Dr. Frazier, he ate a pound of butter. And this was really a distinct change in his behavior. And Mother kept saying, "It's due to this anticonvulsant. I know, he's different." So we finally did a number of medical investigations, and we switched him over to another anticonvulsant. The abnormal eating behavior stopped. He stopped aggressing. He was able to go back to school. An additional level of workup, we had to look at his gut to see if anything else was going on and do some further testing, and it turned out that he was lactose intolerant. And part of what he was doing was drinking a lot of milk products and eating butter, fueled, I think, in part by whatever that anticonvulsant was doing to his tummy. And then the third case, and this is also a point of illustration. When I worked at McLean Hospital years ago, I headed up the outpatient clinic there, and a mother was bringing a nonverbal boy who was 16 to me for consultation because he was on 6 psychotropic medications and continued to be aggressive, and they wanted me to take another look at him to find out if I had further thoughts and recommendations. So they came in the first time, and he was quite aggressive actually in the office. And after the thorough meeting, I had them come back a second time, and while Mom was driving the boy in to see me for the second visit, she called me and she said, "Dr. Frazier, he's projectile vomiting." And I said, "Take him to the emergency room." And they thoroughly examined him and found that he had probably a congenital kidney malformation and had developed severe hydronephrosis. And what was happening was he was in so much pain when he was walking or when Mom was going over bumps in the road. And people were treating the aggression with psychotropics. Happily, he underwent surgery, and we were able to get him off all of his meds, and the aggression stopped. So Now, this is an important slide. The mortality rate is higher in ASD. It's significantly higher in those who are nonverbal and have intellectual disability. The cause of death is typically related to gastrointestinal, respiratory issues, or seizures. And one study found that the elevated mortality rate is related to the comorbid medical condition and intellectual disability rather than the ASD itself. This underscores the need for coordinated care, coordinated medical care for this population. It's absolutely critical. So what can we do? We need to educate and advocate. I think this primer is a really useful tool. A lot of members of our medical community are not aware of these facts. We need to increase visibility and provide education to the medical community. It's critically important to listen to parents. Parents know their children, and they can tell you if something is wrong and has changed. And they may not know what, but you have to go on a journey together to find out what's going on. So there are increasing studies that actually underscore the fact that there are biomedical abnormalities in ASD. This is a ripe area for investigation. It's a ripe area for therapeutics. We know that there are increased findings of neuroinflammation, immune dysregulation, abnormal gut flora, autonomic dysfunction, oxidative stress, and mitochondrial dysfunction. And these are important things to be thinking about, because having something wrong in any one of these domains could have a really negative impact on function and behavior. So this area of allergy is critically important. Individuals with ASD have heightened sensitivities, ectopic dermatitis, allergies to food, food intolerance, and there is a syndrome actually called allergic irritability syndrome, where anybody, regardless of disability, who has an allergy has trouble falling asleep, trouble waking up in the middle of the night, difficulty with irritability, difficulty paying attention. We know that if you treat allergies in individuals who are on the spectrum, that their behavior improves. So it's critically important to get a detailed history, including personal history of allergic disease, dietary history, and family history, and to do a physical exam to accurately identify potential comorbid allergic disease. Treatment of that comorbid medical condition may result in a substantial improvement of quality of life, not only of the child, but also their parents and their siblings, because when a child in a home is suffering and is behaviorally dysregulated, it affects the whole family. Now this slide reminds me of one of the slides that Jordan had in his talk. Okay, if you think about it, he talked about the overlap of genetics. This is my Venn diagram child, diagnostically. These are the type of children that come in to see me, okay? And typically the question is, rule out autism spectrum, rule out bipolar disorder, rule out schizophrenia, rule out ADHD, and it goes on and on. This is how they present diagnostically. This maps on to Jordan's genetics slide. There are multiple domains of dysfunction that are variably impacted in individuals who are on the spectrum. So I'm going to wrap up by talking to you about rates of psychiatric disorders and some of the challenges in our area in appropriately diagnosing and treating children. Part of the problem is there's very little research that's done in this area. You all may know, if you are interested in research, if it's not specifically for individuals on the autism spectrum, they're excluded, especially when it comes to psychiatric research. They're often excluded. It's an exclusion criteria. So we surely know little about little compared to other areas of psychiatric research. And in addition, it's complicated because even if the psychiatric studies enroll individuals on the spectrum, they usually exclude individuals who are nonverbal and or have lower IQ. So the rates of psychiatric disorders vary widely across studies, and there's a problem. We can't really compare studies because the sample selection is often different, and the method for case ascertainment differs. So some studies are chart reviews with Ns of 10. Some involve informant-based information, and some involve direct patient evaluation. A critical source of problems relates to the symptom identification, right? So sometimes a child just can't explain what's going on. And especially if they're nonverbal, how do you elicit from a child, are you anxious? And part of what really limits us, and we struggled with this a little bit on the biomarkers project, is that we don't have good rating scales validated in the autism disorder population. So this is a paper that was written by Santino and Matson in 2009. They were looking at comorbid psychopathology in adults with autism spectrum disorders and intellectual disabilities. And they noted the challenges in identifying comorbid psychiatric disorders in people with ASD. There's minimal research, and there's very little research in adults. Most of the studies that are out there are on children. And most subjects are high functioning. They can articulate the problems, and we exclude the lower functioning youth. I was interested in Eric's talk about the severe autism, because we just don't know enough about how to help them because they are excluded from most research. And I think the study that was recently funded is really going to be helpful to the field. So they also outlined a few other things, that it can be very difficult distinguishing symptoms of psychopathology from core features of autism, just like in the medical arena where they ascribe behaviors to autism. It's true on the psychiatric side too. Sometimes differentiating symptoms from core domains in ASD is difficult. And also, we're dealing with an extremely heterogeneous group of individuals, and it's compounded by the varying degrees of intellectual disability. There are also developmental effects on the psychiatric disorders. So, for example, individuals may present with developmental features similar to younger neurotypical children. You have to really establish whether there is psychopathology, and part of what helps us establish if there's a psychopathologic process is first we rule out medical, we rule out environmental, and then we have to look for a sharp change in behavior from baseline. So you could have a youth who has sleep issues, but what we look for is a sharp change from the baseline in the sleep issues. Individuals on the spectrum can be very complex, as you know, because they have uneven domains of functioning. It's not uncommon to have somebody to come in with complex computer and cognitive skills, while at the same time socially being similar to a preschool-aged individual. So this study was a useful study published in 2009, where these investigators looked at something called the Parent and Caregivers Child Symptom Inventory. It was a DSM-4 referenced rating scale, and everything that I talk about moving forward is not up to date with DSM-5. We've got DSM-5. Jordan had talked a little bit about it. It is changing how we diagnose individuals on the spectrum. There's been a lot of controversy about it, but there's also some strengths about the specifiers in the new nosology. Anyway, this slide really talks about DSM-4. And this particular study, they enrolled nearly 500 youth between the ages of 6 to 12, and they were referred to the clinic with an ASD. They also compared them to controls who didn't have ASD that were seen through the same psychiatric clinic, and they did a factor analysis, which was helpful. And they found, based on their findings, that DSM-4 disorders may be appropriate for characterizing psychopathology in ASD. Still quite a controversy about this, though, because the National Association for Dually Diagnosed actually has its own DSM manual specific for individuals who have intellectual disabilities. And I'm currently involved in updating that particular manual. There was a national survey on child health that was published in 2006 comparing children with autism versus neurotypical children, and they found, not surprisingly, the following things: that children on the spectrum were more depressed and more anxious, they had more behavioral problems, they had more physician's visits, and they received more treatment and prescriptive medications for emotional and behavioral dysregulation. This particular study actually was published in 2006, where Lafer et al. Actually looked at a new instrument and then tried to capture the comorbid psychiatric disorders in youth from 6 to 12 years old. And what they found was not too surprising, at least for those of us who work in child psychiatry. A significant number of them, significant number of them had at least 2 comorbid conditions, if not 3. The top 3 conditions that were found were specific phobia in about 43%, OCD in another 37%, and ADHD in 31%. Anxiety is a huge issue across the spectrum. There are multiple challenges in diagnosing anxiety, particularly this whole issue of diagnostic overshadowing, where people ascribe the symptoms to ASD rather than actually having a comorbid condition. The breadth and prevalence of comorbid anxiety across studies is complicated for all the methodologic issues that I highlighted earlier. Study sample sizes are small. How do you operationalize anxiety? How's it assessed? And studies differ in terms of their sample ascertainment. There have been a number of studies looking at anxiety in youth with ASD because it's one of the most common things that we prescribe medications for. Anxiety-related concerns are amongst the most common presenting problems for school-age youth, for example. The social disability may engender anxiety, particularly in higher functioning youth. And the prevalence of anxiety disorder varies across studies, and it's anywhere from 11 to 84%. And the simple phobias, GAD, separation anxiety disorder, obsessive compulsive disorder, and social phobia are very common. So this is a youth who's really trying very hard to work out his issues at the blackboard. This is a study that I published in 2001, so nearly 12 years ago. I was really interested at that time of the whole issue of possibly a comorbid ADHD in youth on the spectrum. It used to be in DSM-4 we could not give a comorbid diagnosis of ADHD, yet how many of you know individuals who are on a stimulant for ADHD symptoms, right? So it makes sense that it might be a comorbid condition. So we looked at a large database and we compared youth with ADHD versus those with PDD-NOS, those with PDD plus ADHD. And trying to figure out how to do this. There it is, okay. So we had, these are the ADHD kiddos, and these are the children with PDD plus ADHD. These are the ADHD youth. We had 105 in this particular group, 10 in this group, and 50 in that group. And I was just interested in looking at the percentage of subjects who had various symptoms of ADHD. So each tick here is a symptom, and this is then the number of subjects that had it. All you have to do is look at PDD alone, and there are much fewer of them who have any of these symptoms, and you look at those youth with ADHD and compare them to the PDD plus ADHD group, and they have a very similar symptom profile. You look across and a similar profile. So this was, one of the earlier works that looked at this whole aspect of ADHD, and I'm really pleased that we're allowed to give the diagnosis now, particularly because it's helpful for families. If you can give the label and prescribe a medication, it's also helpful, and it's helpful for billing purposes. But we also know that children with ASD have difficulty with focused attention, but they don't have difficulty with sustained attention. Overfocus, they miss the forest for the trees. So sometimes individuals on the spectrum treat people and interpersonal events in a mechanistic kind of way. Now, this was actually a very interesting paper that was published in 2011. At Hopkins, they have something called the Interactive Autism Network. And it's a national online registry that was established in 2006. It's based on parent report. And at the time of this particular publication, there were 4,343 participants between the ages of 15 and 18 years. It allowed for the assessment of community-assigned comorbid diagnosis in ADHD rather than research-assigned. And it examined factors associated with comorbidities such as age, gender, type, and severity of ASD. And this is what they found. This is common practice in the community. It's a fairly large sample size, but they found that about 37% of individuals on the spectrum had a comorbid ADHD, that about 27% had comorbid anxiety, 11% comorbid depression, and about 5% had comorbid bipolar disorder, and approximately 1% had comorbid psychosis. In my clinic, I see a lot of these youth who do have these comorbid conditions, such as comorbid bipolar and comorbid schizophrenia. That's why the genetic studies that are being done that look at overlap, I think, are very, very interesting. And this is a slide that basically breaks the groups down in terms of the percentage of patients who have autism, those who have PDD-NOS, and those who have Asperger's, who have these various comorbid conditions. And as you can see, and I think this is very interesting, that the youth who have an Asperger's disorder actually have a higher percentage of every single diagnosis across the board. Finally, I want to share with you this overlap between anxiety versus psychosis is also an area of interest of mine. This is a study that involved 483 children with ASD, and it examined the boundaries between anxiety and psychosis in youth on the spectrum. They also used the Early Childhood Inventory and the Child Symptom Inventory 4. Children with Asperger's disorder had higher rates of anxiety on several items, and those with more anxiety actually had higher IQ. Those with high levels of anxiety also had more severe ratings of psychotic symptoms, and anxiety and thought disorder may present similarly in ASD versus non-ASD youth. So in summary, the Asperger's group was more anxious even than the high-functioning autism group, and they had more OCD, avoidant, and depressive symptoms than high-functioning autism, and both groups, Asperger's and high-functioning autism, had higher scores than the control group on schizoid and schizotypal scales. So this is a father whose son was recently diagnosed, and he's going to pick up his Prozac. Pharmacy says it's a new antidepressant. Instead of swallowing it, you throw it at anyone who appears to be having a good time. So I'd like to wrap up and share with you some important news. Given all these comorbidities, both medical and psychiatric, that we see in multi-complex youth, there's been a huge gap and a hole in central Massachusetts in terms of cohesive clinical care. Just 2 years ago, Dennis Wall put up a map of the state of Massachusetts. I still have it. I almost put it in this talk. But he had sort of a line where 495 wraps around Boston, and he put little pinpoints in there for all the diagnostic clinics throughout the state that diagnosed children, and there was nothing beyond 495. even though we did have some clinical care at UMass at the time. I've spent 5 years pulling together this project, and we finally launched our clinical program in the middle of June, and we're so delighted. So this is our team, and I'm really delighted that some of the members of the team are here today. Mary Beth Cadlick, who's the program director, Sue Swanson, who's our speech and language pathologist, Kelly Hurley, who's our autism resource specialist, and members also of my research lab who are here. If anybody knows of a BCBA or an occupational therapist who'd like to come to Worcester, we'd love to get their applications. We're still looking for people. I'll just share briefly with you about the evaluation and treatment model. Okay, we've got 3 different stages, and this was based on a lot of feedback from families in the community and heads of agencies. We have an interdisciplinary team that's specifically meant to receive multi-complex children to tease out these comorbid issues that families struggle with. We have multiple members on the team. As you can see, I won't read the list, but instead of doing an interdisciplinary assessment and handing families the assessment and saying, these are the services you need, we actually are jump-starting intervention on the university campus for a brief period of time, for about 12 weeks, while we have a team that's bridging to get families connected in the school systems and in the community for support beyond our Jumpstart intervention. So in conclusion, I think I've reached the end of my time. I'd like to just let you know that we've been on a journey. I've highlighted the challenge of making comorbid medical diagnoses in individuals on the spectrum. I highlighted the challenge of making comorbid psychiatric diagnoses in individuals on the spectrum, and I shared with you about the opening of Can Do. This is my team, my research team. They keep me out of trouble every day, and I thank them for that. And I'd like to thank you for your attention.